A key concept in the management of diabetes is that A1C is determined not only by fasting, but also by postprandial levels of plasma glucose. Even with appropriately titrated basal insulin and controlled fasting plasma glucose, many patients are still unable to achieve or maintain A1C control at less than 7%. In those patients on intensive glycemic therapy with insulin and improving A1Cs, postprandial hyperglycemia is the major contributor to A1C levels. Postprandial glucose levels are tightly regulated by the body. When nutrients are absorbed following meal ingestion, plasma glucose levels rise, which stimulates pancreatic beta cells to release insulin and suppresses glucagon release from alpha cells. Insulin and glucagon work together through their effects on muscle, fat, and the liver to reduce postprandial plasma glucose. Another very important factor that regulates postprandial plasma glucose is the rate of gastric emptying. Following a meal, gastric emptying rate is delayed, which slows nutrient absorption and helps limit the rise in postprandial glucose. Therefore, three critical factors in maintaining normal postprandial glucose are insulin secretion, glucagon suppression, and gastric emptying. In addition, the incretin system must be functioning normally. In response to a meal, intestinal cells release incretin hormones into the circulation, including glucagon-like peptide 1, also known as GLP-1. GLP-1 plays a major role in maintaining healthy postprandial glucose levels because it affects three critical factors. GLP-1 stimulates insulin secretion, GLP-1 inhibits glucagon secretion, and GLP-1 delays gastric emptying. Two classes of incretin-based therapies that increase GLP-1 action are available: DPP-4 inhibitors and GLP-1 receptor agonists. DPP-4 inhibitors increase circulating GLP-1 levels by inhibiting its degradation by the enzyme DPP-4. GLP-1 receptor agonists are relatively resistant to the action of DPP-4 and activate GLP-1 receptors on target tissues. It's important to understand that not all GLP-1 receptor agonists are the same. Within the GLP-1 receptor agonist class, agents can be classified into two types. Prandial GLP-1 receptor agonists preferentially target postprandial glucose levels. Non-prandial GLP-1 receptor agonists preferentially target fasting glucose levels. In the postprandial state, prandial GLP-1 receptor agonists have stronger effects on insulin secretion, glucagon suppression, and delayed gastric emptying than non-prandial agents, resulting in a greater effect in reducing postprandial glucose excursion. The 2012 position statement of the American Diabetes Association and the European Association for the Study of Diabetes includes the option of combining basal insulin with a GLP-1 receptor agonist in addition to metformin in patients who are not meeting their A1C target on a two-drug regimen. Basal insulin primarily reduces fasting plasma glucose and affects postprandial plasma glucose to a lesser degree. Basal insulin can be combined with a prandial or a non-prandial GLP-1 receptor agonist. Combining basal insulin with a prandial GLP-1 receptor agonist may offer a complementary therapeutic strategy. Basal insulin preferentially targets fasting plasma glucose, while the prandial GLP-1 receptor agonist preferentially targets postprandial glucose levels. These complementary actions may provide greater hemoglobin A1C control. In summary, A1C is determined by both fasting and postprandial plasma glucose. Prandial GLP-1 receptor agonists preferentially target postprandial glucose levels. Combining basal insulin with a prandial GLP-1 receptor agonist may offer a complementary therapeutic strategy. Basal insulin preferentially decreases fasting plasma glucose, and a prandial GLP-1 receptor agonist preferentially decreases postprandial glucose levels. These complementary actions may provide greater hemoglobin A1C control. Combining basal insulin with a prandial GLP-1 receptor agonist provides an important therapeutic option for an individualized treatment approach to achieving optimal glycemic control. Therapy with GLP-1 receptor agonists is associated with the limiting side effects of nausea and vomiting, particularly early in the course of treatment. Concerns regarding an increased risk of pancreatitis remain unresolved.